So I told you about these guys before. So this is Al Sacchetti in Jersey.
Snowy Jersey.
Jersey.
Yeah, it looks more like Denver now.
South Jersey.
Which is an improvement.
Hey, snow hides a lot of needles and bottles and everything else.
And Jimmy Hoffa.
He's been buried.
And Billy Mallon. Billy's USC. Been there for, what, 15 years now?
Yeah,
Minimum.
unbelievably. When I first went to Los Angeles from Boston, I said, there's no way I'm staying. Train, I'll be back in Boston on the first flight out when my residency ends. Book it now. Yeah, didn't work.
And these guys have been with us since the beginning of this thing. And these courses began, I think, about 1985, thereabouts. What we're going to do now is something a little different. You got this section on ethics in your book. We want you to participate in this. We picked out some papers on a variety of topics.
It seems a little odd you're doing an ethics talk in Las Vegas.
This is the home of bioethics here.
Yeah.
This is the,
Bioethics versus monetary ethics.
No, what's odd is to do a talk about statistical probability in Las Vegas, because the statistical probability is you're going to lose, okay? I always love these things in the casino where they say, this is where players win and winners play. No, this is where losers play, and that's how they built the place.
And there's
What are
guys,
you trying to say?
Yeah.
Don't do it.
There's guys with broken noses who look for people like you around
I
here.
understand
Yeah.
that. Yeah.
those of you who are primary care doctors, you're welcome to stay here, but the primary care sessions are around the wall and on that side over there. Because we're going to be talking about the primary care doctors now. So let's do these first set. And to set the tone here, performing procedures on newly dead people. How else are you going to learn? Well, apparently there's some ethical issues about that. And all of these people who wrote here, except the last ones, say that this ought not be done. And that there are ethical and legal issues that say we should not do this unless we have permission of the family or permission of the patient. And only the last guy here, who wrote the last two papers, said, no, it's a societal kind of thing and we really need to do it. And there's some implied ability to be able to do this. This is long-standing tradition in medicine, and that their societal goals are such that we expect people to be able to take care of us and do these procedures on us, and this is the way society teaches people how to do those. So where do you stand on those things? Do you do these?
How many of you work in a teaching institution where this stuff comes up, hey, the paramedic comes up, can I intubate that guy that you just pronounced? So how many of you work at a place where you do a little bit of that kind of stuff or have residents? So this is a big topic, and there's kind of two versions of it. One version of it is the intellectual honesty to say, Bob is dead, now let's play. Then there's the less intellectually obvious version of it, which is to say, Bob's not quite dead. So there's the non-dead, but soon-to-be-dead procedures, which we do all the time, which is quick do a thoracotomy. I mean, 90% of all thoracotomies are, Bob is dead, but we're going to cut his heart open and look at it. So you could make the argument that the vast majority of thoracotomies are the same thing. And so some people say, oh, well, Bob's not quite dead, but we seem to be having trouble buying him. Have you done a crike yet? Crike Bob. And so there's a fair amount of teaching that goes that way. Some of the things, the problem with it is that the really invasive procedures, thoracotomies and cricothyrotomies, which deform and disfigure, are the ones that are not being talked about. So Ken Iserson's papers, if you look at 6 and 7, talk about sort of minimally invasive procedures and that they're not really that disfiguring. And so most of the disfiguring procedures are done on people who we're pretending aren't dead, but we know we're going to call them dead soon.
What's interesting is you look at the first article, and it just shows a different mindset, where they compared a bunch of people from Norway with a bunch of people from Brooklyn. Now, those are two kind of similar populations.
Yeah,
maybe.
right. Yeah, those are exactly the same.
I mean, I don't think anybody in Brooklyn's ever seen a sardine. Long story short, though, is when they talked to the people from Norway and said, what do you guys think about it? they said, we think it's a wonderful idea. And then they asked them, would you be angered if someone came up to you and said, listen, your mom's dead, but we've got an intern here who never did a CVP. We want him to try it on your mom. 48% of the people in Norway said, yeah, that wouldn't bother me too much. 8% of the people in Brooklyn said it was okay. The others said that they would punch out the person who asked them, that they would find it very offensive and become very angry. I don't know that it's unique that it was just a physician asking them something. I think 90% of the people in Brooklyn might punch anybody out. But aside from that, it's very clear that there's a huge ethical difference, that the people in Brooklyn view the deceased as part of their possessions, and you're messing with their possessions, whereas the Norwegians have a much different approach to it, which would be, you know what, it's okay. We can understand why you would want to do that.
There's another point that's made in the first paper, which is that the patients themselves, if you asked patients before they were dead, of course, it would be nice to ask them. If you asked them before they were dead whether they thought this was okay, a lot of them said, yeah, do whatever you want with my body once I don't need it, feel free. But when you ask their families were much less likely to consent. So there is some actual loss. Well, some people say, well, you're stepping over your bounds and there's no autonomy here, and you have to get consent from the family. Actually, the family has a hard time knowing, apparently, what the patient would consent to. So the patient may actually lose consent, lose some autonomy. And this, by the way, is a big topic in the futility papers, where patients have clearly said they don't want to be resuscitated in many venues, but they lose autonomy because the family panics at the end and says, do everything for Bob. When Bob has said, no, please let me go. And so here Bob says, yeah, they can do whatever they want to me, but the family says, oh, no. So there's harm on both ways. If you want to take patient autonomy and consent, there's actually harm on both sides. On one side, the patient says, geez, I'd like to do one last good thing with my body and teach an intern how to do a central line, and the family denies them the opportunity to do that.
Yeah, you can even ask them after they're dead, but you have to phrase the question right. Do you mind? He didn't mind.
That's right.
Yeah, they didn't object at all, so we went ahead.
Well, if you take a look at the last sentence in number 2, this is the American Medical Association says that if reasonable efforts to contact the family members or gain permission are unsuccessful, they believe that training procedures must not be performed.
Yeah, must. And they went on to identify in abstract 2, if you look in the middle of that section, apprehension and discomfort on the part of trainees, medical staff, and nurses during these training sessions can pose problems and risks, aka whistleblowers.
Yeah, that's happened on a number of occasions where it's been the norm in the hospital setting that was always done, and then for some reason or another someone got annoyed and wanted to get back at someone and went and told the family that it was going on and created all kinds of problems.
Let me raise a different issue. If what we want is to maintain high skill level, actually intubating dead people is not the best way to do that. What we did with our EMTs and that sort of thing is we sent them to the operating room and let them do it with an anesthesiologist on live people, where it's much more difficult, but somebody there who could step in when they needed to. And so if the goal here is training excellence, then maybe we ought to think, are we actually producing with this disfiguration of the body after death, are we producing the training that we really want? Because if we're not, why do it? The question of opening the chest, I agree with Billy that 98% of all openings of the chest are the first stage in the autopsy. Yeah. If I look back over my career, basically that's exactly what opening the chest has meant, is that we're kissing them goodbye. Yeah, I suppose that's all right. But if they're now dead, and you're saying, well, now open the chest for teaching purposes, bottom line is, what are you teaching? Because the heart isn't pumping. There's nothing you're going to stop. You don't even know whether you've hit various organs or not. I mean, I think a lot of this post-mortem training on these people is not terribly useful as a training technique. We really need to define it.
Oh, it's still a lot better than other. I mean, you open someone, you learn what it's like to use the rib spreaders, you learn what it's like to deliver the heart, you find the phrenic nerve, you're looking at live tissue, it's not been embalmed. I mean, I agree it's not the same as doing it on a live person, but it's certainly the best training available. And if you'd like your survivorship from a thoracotomy to be 10%, then you need to do the other 90% and have those people die. Otherwise, when there's actually a viable one, you'll never get it done in time, which is one of the issues that happens when you look at trauma centers in terms of whether or not they're facile with those procedures or not. I mean, we do about 60 thoracotomies a year, and it is those 60 thoracotomies a year that allow the 10 who are going to live, so that the 50 who die are basically dry runs for the ones who are viable.
But these aren't really the procedures that they're really not talking about.
Right, not the almost dead. They're talking about the, you'd call them dead.
Yeah, no, but they're not talking about doing thoracotomies
Right.
on the recently deceased. They're talking mostly about intubations and CVPs.
Yeah, right.
Yeah.
So
Ken Iserson goes on to point out, if you look at the last two articles, that autopsy is a lot more disfiguring than even the most disfiguring procedure we would consider. I mean, most autopsies start at the Y, right? They do a Y-shaped incision and then go down through. And so the concept that even a thoracotomy is disfiguring in the setting of an autopsy, Ken Iserson points out, that's craziness.
yeah, but not everybody gets an autopsy. Raise the question that you and Greg had talked about earlier, which was switch it around, change it so that society makes you have to opt out of having anything done. So that the societal norm will be, if you pass away in a teaching institution, after the family says goodbye to you and everything else, that the interns or the less experienced will practice on you. Make that the norm, and if you don't want that to be done, then you have to opt out of it, which solves the whole issue.
That's
Yeah, which
the,
is abstract 3. Abstract
it's
3
at the bottom
talks about the
of number
mandated
3.
choice in which consent regarding various issues is made a matter of public policy. This was done for organ donation all over Europe. Of course, we're not progressive enough to do it here. So in Spain, Italy, the Benelux countries, they said, we're going to assume you're an organ donor unless you get the pink dot on your license that says you're not. And that way we're not going to have to find people to harvest you. As opposed to the current situation in the United States where you're assumed to not be an organ donor unless the pink dot's there. So this argument has been made for teaching on the newly dead, that we should have a similar system where we create a public policy, everyone knows about it, you have the hullabaloo saying we're changing to this. If you don't want your remains to be desecrated in this fashion, then you need to get something that says I don't want that. Otherwise you will be assumed to be a player.
And the other thing is, I think the simulators are actually getting
better.
Yeah, I mean,
Yeah, but who can
We got a
afford those
simulator that'll
simulators?
burp if you're putting in the NG tube wrong. I'm serious. We got one of these. Of course, it's all part of national defense. You understand?
Right,
and
right.
security. So we got through the Navy program at our place some $600,000 simulator that probably would do well here in Vegas, but it has all the functions that you can imagine. I mean, it's just unbelievable. And the person programming it, we used to play Stump the Chump when we were doing ACLS. You'd be, the person with the rhythm generator would be over there stumping the resident and creating. Now you can play Stump the Chump with a mannequin. Go ahead, blow the pupil and make her burp. And you can do that, and it's just unbelievable what you can do with these mannequins now. So the argument that in terms of resuscitation you can't train any longer, simulation really has provided a counter. By the way, that counter argument in favor of simulation is so powerful that the most resistant to the whole concept of simulation, who would that be? The surgeons. So the American College of Surgeons, via ATLS, finally allowed simulation instead of pigs, dogs, goats, and sheep. So the PETA people used to be pretty upset because it didn't seem to be a very compelling argument to kill a pig to learn ATLS. And most people who did kill the pig in ATLS, the only thing they really learned was pig anatomy, because most of it had placed chest tubes and done all those things already. And now ATLS finally is allowing simulations, approved simulators by the American College of Surgeons, to be used in the ATLS teaching. So simulation has definitely come up to a level where you can do things. But I still don't think it'll get you a crike that's realistic, and I still don't think it'll get you a thoracotomy.
I think you have to use a deer head to do a crate. That's the latest article I saw. Yeah.
Well, that survey shows that that only 8% of people in Brooklyn wouldn't mind. I mean, it seems to me that's if you even extrapolate that across the U.S., I mean, you're going to have the majority of people would be upset if they knew about it.
Yep.
And that's one point. And the other is, how valuable is it really? If they do this one procedure, or maybe two on a recently dead person, I mean, how useful is it unless they're doing them all the time to reinforce it?
You bring up a good point, because the two procedures that are commonly done are intubations and CVPs. Intubations you will get practice on, just in the description that Greg said, plus in the emergency department you can get practice with an attending standing over your shoulders. CVP, same thing. You're going to put lines in people and you're going to get a chance to do that. It's the oddball things, the cricos and those kind of things, which we don't do.
You're going to forget by the time you want to do that.
Well, yeah, and the other thing is, I think emergency medicine is one of those fields where you have better be able to have read about a procedure or heard about it and then perform it without ever getting any practice at it. I mean, it's all of us have had to do something that we've never seen or done before, because no matter how long you practice or in what institution you train at, you won't get exposed to everything. And part of the training of emergency medicine is, how do I approach a problem I've never seen before, but I kind of know what needs to be done?
By the way, when Billy talks about USC, that's 3 standard deviations away from most training programs. I'll tell you right now, we have community-based emergency medicine programs. Michigan has 21 emergency medicine programs. We have plenty of programs where the resident will finish and will have never done a crike on a live human. It won't, and because we have, first of all, the good news is we have so many other airway techniques these days.
Yeah, with rapid sequence and the other airway
Right.
techniques, if you
don't have to do
you
it.
find me a new grad who does 20 crikes, and I'll show you a new grad who needs to go back and learn how to intubate.
Right, exactly. But believe me, a lot of these skills are atrophying. We'll even talk about that in the papers on lumbar puncture, that some of these skills are sort of atrophying, and probably at some point in time you should have had some interaction. By the way, this is a legal question, not a medical question. In the state of Michigan, the Supreme Court in the state of Michigan joined about 6 other states and has said...
Is Michigan in Canada?
What?
Is that in Canada?
No, it's not.
No, just checking.
There's 6 other states that have also said that the people who come after you don't have specific property rights with regard to the body. And so it was not clear that you had committed some sort of heinous act for which they could be compensated if you'd done this practicing on the body. So it is a state-by-state issue as well.
Although the U.S. Sixth Circuit in number 4, which overrides local states, basically says that a ruling is the next of kin of a property interest in the patient's remains and may have a rightful claim against institutions for infliction of emotional distress if procedures are performed on newly deceased patients in the absence of consent of the family. So I don't know which takes precedence in terms of which is the most current. There seems to be some law underneath this as well. What are your thoughts on this? Are you okay with it? You're not okay with it? Do you do it? Do you not do it?
I will tell you when.
What's your favorite? What happens in Vegas stays in Vegas.
Yeah.
So what's your favorite thing to do with dead bodies?
Is anyone doing intubation training with them? So, don't? And what state are you in? Wisconsin.
But it's not a state thing. It's just a matter of.
This guy over here.
I work in a very small hospital. Our ambulance does about 1,200 runs a year. And we meet EMT intermediates, ET crews in the field. You can imagine they don't get enough ET tubes in the field to keep their skills up. So we do ET tubes in the ER on newly deceased patients.
They do it, you don't. And it mentions in one of these papers here talk about the uncomfortableness of house staff sneaking this in. It's like quick, like, okay, well, all right, let's go, pull the curtain, that kind of stuff. There's a certain sense that is kind of like doing something that is not exactly kosher kind of thing.
Which is why Ken Iserson wrote his papers trying to say, no, this is an ethically defendable. I think the bulk of the literature doesn't support Ken Iserson's papers, which are the last 2, 6 and 7, but Ken Iserson has spoken out twice about this as an ER doc saying, no, this is an okay thing to do, and he provides his rationale for it. I think that the bulk of people looking in on this from the outside, though, have concerns about it. I mean, I think that's just where it is. I think it's better to say the person's not dead and continue with your resuscitation, because that's something we do all the time. For example, with thoracotomies and things like this. I mean, we coded some guy, we had a resuscitate Annie, I was working last night, we coded him 10 times. He was like a practice session. And you pretty much know what the outcome of that patient's going to be, which we're going to talk about a little later, which is futility. At which point should we stop? But if we're not going to stop, if the family's there and says we're not going to stop, then that's a resuscitate Annie. Do whatever you like.
You want to do number 2 is problem patient lists.
Yeah, I like that topic.
I like that one.
Do you, this is about, well, the first paper was written by, number 8 was Joel Guiderman. Joel is very ethically concerned about problem list. He's also one of the people, oddly enough, who wrote substantially about these TV shows that were doing the photographing of the ER kind of shows where you're live and they're taking pictures of people who are
So
coming
he
into
helped
the
create
ER.
the position statement saying it's unethical to have filming crews in the emergency department, even if you get retroactive consent, because it's too vulnerable a population. So if anyone strolls into your emergency department with a camera, there actually is a position statement saying, no, this isn't the forum in Rome. We're not here to see how the Lions did.
But obviously not everybody agrees with that, because you see all of these emergency shows all the time now where people are, what is that, on the Learning Channel they have all
Life
of these,
in the
Life in
ER.
the ER.
They came to our place.
And he says you can't do that because it requires the retrospective permission of the patient, which is what they obviously have to do. So there's obviously a difference of opinion here. This is about keeping lists of drug seekers, calling them something more euphemistic like habitual patient files, and sharing that information back and forth between hospitals. How do you put information in there? How do you share it? What are the HIPAA issues, et cetera, et cetera?
Yeah, I think HIPAA's laid this out very clearly. Number one, you can't have a patient record which the patient does not have access to. That's pretty straightforward. Now, a much better way of calling it a turkey book or this or that, just flag charts with a star that says see old charts. And that way, when those names come up on the computer, they have to bring the old charts up with it. In fact, we now have a system where everybody, every time you get a page printed out with their visits in the last 2 years.
Right, and that solved the whole problem.
And that solved the whole problem. This keeping a book, and by the way, you're not necessarily right. Because some brown shirt nurse has said, well, they're a drug seeker, they may actually have a real disease. I think you can prejudice yourself against the patient by walking in with too harsh an attitude, moment one. You know what? They get their shot at it like everybody else.
There are some real diseases which predictably produce a lot of visits. You got sickle cell disease, you got a bad life, you got a painful condition, you're frequently going to need narcotics, you're going to go to the emergency room a lot. I mean, it's pretty clear that that's the case, and so there is some prejudice. Both of these papers talk about these issues of one, how you enter, whether it's secure, does the patient have access, are you sharing information between places? Because it's quite common for the local ER to say, and I got some guy here who's, the usual, allergic to Haldol, that means it works. Allergic to Toradol, Motrin, you go down that list, that means I need a narcotic. And of course, there'll be other allergies in there like Compazine and things, so you won't attempt to manage their migraines that way. And so someone will call the neighboring ER and say, hey, we got this guy here. You know him? I noticed from his zip code that he lives closer to your house. Yeah, he had 650 visits here last year. We told him never to come back. And so there is this sharing of information, and a lot of people are quite hip to it, right? You can tell when it's happening just by looking at where the person lives and where they came to. They bypassed 3 hospitals to come to you. That's because they exhausted the narcotic supply at those. And so there was this attempt to share information. These papers, I think, make it very clear that you are not meeting the HIPAA guidelines if you do that the patient hasn't consented for that exchange of information, they don't have access to the information in the turkey file, and then unless you create these special needs files, and in fact, at one of the hospitals that I work at in the private world, a little company Mary, they actually send them a letter. We put you in the turkey file. It doesn't say the turkey file, but it says we put you in the special needs file, and as part of this letter, which tells them we know who you are, we flagged you, you're in trouble. They say, and of course, here's a list of our pain management specialists for you, and here's these other resources, blah 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 blah. But basically, they announce to them that you're now in the turkey file, and you hit the century mark, whatever it is. For 100 visits.
You're platinum.
Yeah,
you're a platinum member.
Just made platinum.
Go ahead.
Yeah, I was just going to say, there's 2 points. One is, you never needed to create this turkey file or whatever you want to call it. Everybody who works there knows who these people are. You didn't need to put their name in a book to say, oh, look, they're in the book. Number one. And number two, it is not a HIPAA violation to call another hospital and find out if someone was there or not. You don't
Correct.
need their permission to do it. It's for part of their continuing care. So you're allowed to do that, and you're allowed to share that information. If someone calls you, you're allowed to say, yes, that person was here yesterday. I pulled the chart. This is what they were here for. This is what they received. That's absolutely legitimate. But it goes back to Greg's early point. You don't need the book anymore. All you have to do is say, hey, Martha, do me a favor. See how many times John was here last month? And they kick it out for you, and here's what they were here for. 15 visits for a toothache, 3 for back pain, and 5 for a headache. You don't need to have a turkey file to
You notice kidney stone's not in there now because you can prove that I'm so wrong with a quick CT renal survey.
Yeah.
Used to be kidney stone. Now they've had to retreat to toothache.
Yeah. But I will reiterate the point that the last thing you want to do when you walk in that room is have poisoned the well for yourself. Which I tell you, everybody's got hot buttons. Each one of us is manipulated by our own hot buttons. Yep. There are phrases you see on that chart which blind you to an objective view of that patient. And I don't think there's anything which is a more common across-the-board hot button in emergency medicine than the term drug seeker. You know what? When somebody comes in with asthma, we don't say, oh, another oxygen seeker. Okay? Oh, well, you want to hit an oxygen? I mean, what about carbon dioxide? Oh, no, only oxygen will do. Well, you know what? There are genuinely sick people who need to be cared for. I think the sickle cell people live a miserable life.
And Jerry has pointed out, when someone comes in and says, doctor, I need Demerol, and usually about 200 works for me, that seems to be a button for us. But when someone comes in and says, I need insulin, and my dose is 12 and 24, we're like, okay, great. And in fact, if they come in and they say have insulin, you say how much, and they don't, and you're like, well, what the fuck is wrong with you? How could you not know? And then the person who knows what they want, what they need in narcotics, we're like, that's a problem.
What do you do with these patients then that they're drug seekers that come and seeking their drugs? What do you do?
That's a whole different.
That's a whole different thing.
But there's a number of approaches. First, my approach is exactly what Greg said, which is I don't go in with a chip off my shoulder. It's like, John, you're here again. What's the matter? And then they'll kind of give you the story. It's like, John, I saw you last time for the same toothache. You promised me you were going to the dentist. What are you doing back here? And the usual story, my dog ate my dental card, whatever, type of thing. And they always have an explanation for it. But I think you start out the encounter on a little bit more of an upbeat. You get less of the pushback, and then you wind up bartering. It's like, all right, I'll give you Tylenol number 3.
By the way, the hidden crime in America is junkie dogs. I've never seen a dog eat a prescription for amoxicillin. Never happened. They only eat for heavy narcotics. Yeah.
But the way you approach those patients is a whole different thing. And usually it's a little bit of a bartering session right there, and then you somehow or another get them involved with whoever your referral pattern is. And the deal is, John, if I see you back here again and I can't prove that you went to this clinic or went to see this doctor or I made an appointment for you somewhere, you're not getting anything.
Yeah, by the way,
some people would say that's, and I agree that that's usually what I will do too. And I don't have a problem with treating them while they're there. I'll do limited prescriptions on the way out. But even whenever you do that, or whenever you do the barter thing, somebody on the nursing staff or in the place will come up to you and remind you, you're feeding the bears.
Right.
Don't feed the bears. No matter how much you give them, they'll just come back. So it's telling someone, geez, I'd like, the person's hungry. You'll say, can we get him a tray? And then the nurse will go in and say, this is not McDonald's. And then when she comes out, she'll glare at you, and you'll say, what? And she'll say, don't feed the bears, which is a common theme in emergency departments, that if you feed the bears, they will know where the dumpster is.
The greatest damage done with these patients is not to them. It's to you and to your view of the next 10 patients who walk in the door that day who have pain. And I think it can jade you into, and believe me, I have nurses who work with me who are very good nurses who've been there for 30 years, but you know what? They don't have a sense of humor about this, and they can become real ugly to these patients. Bottom line is, COBRA says you got to see everybody. You have to evaluate everybody. You might as well go in with a good attitude because you got to do it anyway.
I'm glad you mentioned COBRA, because in California 2 years ago, there was a case brought by a migraineur. Now, she didn't say that was her occupation, but she was a migraineur by trade.
Migrainess.
A migrainess. And she presented to the emergency room for treatment, and the ER doc in California made his best assessment and said, I don't think you should have narcotics. I think you need to see a neurologist or these other options, blah, blah, blah. And so he didn't give them, and she brought a COBRA suit against the hospital for failure to stabilize her emergent condition. And the outcome of that eventually was, Rick, do you know what it was?
I don't recall the outcome, but just the idea that they come and examine your hospital, and Medicare people are there with a gun to your head saying, listen, if we can't prove this, we're going to shut this place down.
Yeah.
Anybody who's ever had a COBRA investigation at their hospital never wants to go through it again, kind of thing. And we had a similar situation. It wasn't the same one. A woman called us after one of our doctors failed to treat her adequately and said, listen, I was in your department, I was not given adequate pain medication. If she had made that call, not to us, but to the Department of Health Services, LA County,
There could be trouble.
acute pain and severity of acute pain is, HCFA defines the presence of acute pain as an emergency. So to the extent that you don't address that adequately, stabilize them, those kinds of things, they can use this against you. And that was a real good example. She just made the wrong call to the wrong person. Had she called Department of Health Services, we would have been in trouble.
Which is why now in California, the first state to do so, because docs have seemed to have done such a bad job, both with pain management and end-of-life issues, which is the next topic, they now mandate for all California licensed physicians 12 hours of pain and end-of-life training. And it's painful.
Get it all done at the same time?
Yeah, we do.
How many here have had a frequent flyer who everybody just blew off only to turn out coming back dead like 15 minutes
Oh,
later?
no, they all die eventually. A
They
lot
all
of them
die of
have
something.
bad disease. They
Well,
all
actually,
die.
I think, I don't know, I think alcoholism and a seizure disorder is the key to immortality. You just can't kill
No,
those
no,
people.
no,
No, no.
Trust me, they die rapidly. In our place, we're a center of excellence for that. That's for that pathology, and they die a lot. Trust me, they die a lot.
Well, you have these patients who have back pain, and you kind of, the nurses roll their eyes because there's a back pain patient here. But, you know, the guy next to me reviews all the lawsuits. That back pain patient who comes in back and back and back again. Yeah. And oh, by the way, yes, they were, frankly, a drug seeker. And yeah, you did see needle tracks, and they were. But that back pain is now due to a disc space infection or a epidural abscess that resulted as a result of that. But because they were
If you'd only
drug
prescribed
seeker,
more Vicodin, he wouldn't have had to shoot up, and he
Right.
wouldn't have got that disc space infection.
We had that exact case. Woman who pissed every nurse off. She was a hooker who also used drugs, back pain all the time, comes in.
My mom?
Not your mom.
Just
In
checking.
any event, now she's paraplegic. And she was sent home, again, and the correct exam, you know, checking the reflexes, sensation, inner thighs, extensor hallucis longus, checking for bladder, all those things which you would do on anybody else with a back problem wasn't done on this case.
So there are two comments that always come out with this, which is in med legal circles, one of the common sayings is the biggest obstruction to the correct diagnosis is the current diagnosis.
Right,
And so
exactly.
if you start with drug seeker, that will prevent you from reaching the correct diagnosis. And the second thing to remember is the phrase that is often iterated, which is, you know, having psychiatric illness doesn't actually provide any protection against other disease. So, you know, the point is, yes, they are a turkey. It's your job to rule out Thanksgiving.
Right, exactly, right.
Yeah, but there's another side to the issue. In the ER work in we have about a 4-hour wait. We have a guy who's been there, I think, 17 times in the last week under 5 different names. He has a very distinct deformity that you can tell it's the same person. It takes an average of a half
What
hour
hump?
each time to deal with them. And they're tying up the ER.
Absolutely, you can get paralyzed by this. I mean, and I'll be honest with you, and I've known Greg for a long time. When we get busy and the frequent flyer back pains come in, they get sit in a chair, then they're not undressed, nobody checks the reflex, nobody nothing. What are you doing here? I ran out of my Percocets. Here's a Percocet, get out of here. We need the bed. And you can get paralyzed, and your practice environment's going to dictate that. I know that Greg will personally rip my head off when that guy comes back, you know, with his spinal epidural abscess or his aneurysm or whatever. But there are times when you just can't do anything but that.
I'm not going to rip his head off, but I will have to go and defend him, and that's real expensive.
any of your views on this, please?
I had a question regarding, just last week, one of my colleagues saw a patient for abdominal pain, female patient, got the full workup, CT, then pelvic ultrasound, received numerous doses of Dilaudid, Benadryl, and Ativan, and eventually she was signed out to me, and
Thank you very much for this very interesting pass on.
Yeah.
Yeah, what test did they order just before they signed it out to you? That you had
Sed rate.
Sed rate.
A sed rate is the key. You got to order a sed rate 5 minutes before the end of your shift.
Yeah.
The comment on the chart at that point is KTMFO. I'll let you work on that for a little bit.
No.
You know, I will tell you the one drug that works on those people, and that not everybody can use, especially when you recognize them early, because we've got a couple people like that. You give them droperidol. As soon as they hit the door, droperidol is, interestingly enough, it kind of about an hour later they sit up and they go, you know what? There's really nothing wrong with me. And it's not akinesis. They want to get out of there. They go, I'm just being, a jerk, and I don't really have anything wrong with me. I'm going to go now. You go, okay, and they leave on their own.
I agree, droperidol. So now we get into the whole thing about the QT prolongation, the black box.
Black box warnings.
But droperidol is a great drug.
And it potentiates the narcotics. So you're giving it to them because it's known to potentiate the narcotics, not because you think they're manipulating the system. And it does. It just kind of mellows all that kind of facade away from them.
If it sounds like we're vamping here, we are. And that's because I've never been in an emergency department anywhere. And I've been all over the United States. They always say, well, you don't understand. We have a different patient population than you do. No, you don't. We all have the same group of people.
They just go around.
They just go around. In fact, there's a society someplace which sends these people out. And they're everywhere. And it is not, there is no one simple answer to these people. All I can tell you is this: the more you can give them an individual look each time, the better it is when we have to go defend you in court.
I like the...
If she's given a whole bunch of water and that and that, kept it for several hours and there was serial exams or 12 hours of testing, is she gonna,
No,
if that lady sues, is she gonna have a chance of winning?
none.
No.
No
But
lawyer wants that
But
case.
you can also build the argument that, okay, we'll admit you for pain control. I mean, there's two sides to it, but I don't think, I think to win in a malpractice suit, you have to have damages, and I'm not sure what the damages are there.
You remember, there.
Damages of any of the people that's suing for acute pain control.
Well,
They're gonna die of pain.
but this is not about malpractice. This is about HCFA and Medicare coming in and giving you one
Right,
of
so
the...
COBRA doesn't require a bad outcome, right?
Right.
So if it's a COBRA thing, you can't go through the stop sign, have the cop pull you over and say, hey, look, I wasn't in an accident, no one got hurt, what's the big deal? You still ran the stop sign, you're getting the ticket, and that's the way COBRA works. A bad outcome doesn't have to have occurred.
COBRA is a procedural question, not an outcome
So
question.
what did you do? Pass them on to the next doctor? Or did you...
No, she got a prescription of Vicodin follow-up arranged with GI and said, I said, read what form, I wasn't gonna give any she got over 10 milligrams of Dilaudid.
I mean, you do have to move on. At some point, you have to move on, and you put your foot in the stand, and you say, it's not a COBRA violation if I've done everything possible, and I can't prove, that there is anything that further that needs to be treated on you. It's a little tough. I'll tell you, though, in talking about the subculture, when I was a resident, there was a particularly seedy emergency department we used to work in, and we had a lot of frequent flyers, and there was a particularly obnoxious individual. The nurses and docs got together and bought the person, and this was in Philadelphia, they bought them a ticket to Florida.
No, this happened in Florida.
And we
The
said-
hospital in Florida that was routinely, after they had more than 10 visits, was discharging their homeless with a one-way bus ticket to New Orleans. And the mayor of New Orleans found out about it.
But we sent them down there, and they were going for 6 months and showed up 6 months later. And we said, oh, geez, you made it back. And they had like a collection of armbands from all the emergency departments they visited. And it was like they went on vacation, and their vacation was to visit the emergency departments in a different city. And they were like, oh, this one was very nice, and they had good food here. They didn't treat me so nice in this place. And they had this whole little litany. It's like they had a little travel log built up of their
This
trip
could
to
be a
Florida.
public TV travel log. I mean, I can't you just see it now?
Topic 3 is medical futility, CPR consent. Now, what is this about here?
It's about when you can just not do it because it doesn't look like it's going to help. I lectured down at the Australasian College of Emergency Medicine. I participated in a debate which just shows how far other communities have moved in this. And the debate was, you're 80, you're DNR. That's what we'd like to be the policy in Australia. We think you had an e-ticket, it's punched. I'm sorry, you're 80. That's it, your DNR. They were looking at age cutoffs. I recommended they also take away their driver's license at that point. So that's kind of where the debate is in Australia, looking at age. You know, it's quite predictable what the counter-arguments would be, which is that physiologically people don't age the same, and there are some 80-year-olds who are in much better health than some 40-year-olds. Probably true. And so there's this whole debate that goes on. But that's the level at which their formal college is approaching this, saying, we understand that when you're 80 and you code, that's probably a bad day for you. It's very likely to be the last day. And the other part about this that people don't want to talk about is the resource stewardship issue, which to me is the most, since I work in a county hospital that's unfunded and always doesn't have enough beds and is always threatened to be closed, that they say that you spend 90% of your Medicare dollars in the last 10 days of life. If we only just knew which 10 those were. The argument to that is, if you're 80 and you've had a cardiac arrest, I'm pretty sure this is those 10.
Yeah, by the way, the cardiac arrest question is not the question on the table. That's the 1% of the dollars. Bottom line is, pretty much when they come in to see me, if the EMTs haven't woke them up in the field with 2 heads of electricity, you're a dead guy. Thank you very much. Have a nice day. We're not going to do anything else. The real question is when you come down to, for example, putting in a feeding gastrostomy tube. In England, it was very interesting. The British believe this to the core of their soul. If you can't ask for lunch, you don't get it. Okay? It's time to die now. They don't put in feeding gastrostomy tubes on people who are mentally defective. I did a short study on a place called the Bortz Nursing Home in Ypsilanti, Michigan. And to get into my study, you had to have been in contractures and not spoken for a year and a half and have a feeding gastrostomy tube in. And then I did the cost of maintaining those people, the medical cost. You realize they averaged 8 trips a year across the street to the emergency department to take care of their pneumonia, urinary tract infections, that sort of thing. Then what I did is I showed for that much money on that one nursing home, you could put a teacher's aide in every elementary classroom in the city. And so when I presented this material at sort of like the Lions Club or something like that, I said, I want to ask you a question. Would you rather spend money on people when they have a chance of being tax-producing citizens, or do you want to support rotting flesh? You have a choice. What do you want to do? This stuff isn't a medical question. This is a societal question.
Absolutely, and that's why it was interesting in Australia. They were asking it from a societal perspective. One of the problems with all of these things when you start moving after these older populations is just how powerful the AARP is. So, for example, back to the driver's license issue, there have been multiple attempts in multiple states to make people who are over a certain age recertify and prove that they can actually see the road, let alone know how to operate the machinery inside their car, and the AARP defeats and waters those down at every turn. This was why we got the drive-through open-air market in Santa Monica where that guy killed
I spent 3 years doing political things in Washington, and let me tell you, there are 2 groups you do not mess with, the AARP and the American Rifle Association.
What about the chiropractors?
The chiropractors are not quite as bad. But the Rifle Association and the AARP can mobilize membership on a moment's notice, and those old ladies got nothing better to do than write their congressman. And whenever you start talking about real change in healthcare, real dollar changes, it talks about resource utilization and things we will not do. And every discussion without that is a waste of time.
How many people have gotten into the situation? Well, I'm not going to ask how many. Everybody has. Where they bring in just the type of patient that Greg's talking about. They come in from the nursing home. They've got their agonal respirations. And your first comment is you look at you flip through the chart for anything that looks like an advanced directive, and obviously either there is none or there's something that's 15 pages long that you couldn't read during your entire break. And then so now you get a hold of the family members, and your quick question is, do you want them on a ventilator or not? Am I intubating this patient or am I just making them comfortable? And you get the family member who says, oh my God, no, I want everything done on grandmom. And you feel like an absolute heel, but you go ahead and you put the tube in them.
I think we've all been there. I think
exactly
we've all
right.
been there,
And
where you felt bad about a resuscitation
Yep.
that in your heart, I'm not talking about the ones where you don't know, but the
Right.
ones where you knew in your heart you shouldn't have done it.
Right. And now if you look at the first article, what it says is physicians have never been required to offer therapies that are not useful.
Exactly.
Which says that if you know that putting an ET tube in this person is not going to make a difference long term in them, you don't have to offer that to the family. You can absolutely say, This is someone who, your mother, your sister, whoever, is dying. We're going to make them comfortable. We're not going to do anything else. And I think it was it you who brought up the point that it depends if you say your family member is dying has an entirely different connotation than if you say your family member is very sick. Very sick means you're going to get better. Dying means you're not going to get better.
Yeah, no, I think that's true. One of the other things these papers make a note of is that a lot of people have actually verbally or otherwise discussed what they want done with them, but the family members or the nursing home or whoever is serving as their proxy at that last moment panics and calls 911. And the reason is that obviously out there in the lay world, people just aren't comfortable with someone dying in front of them. It's, you know, outside of Los Angeles and a few other less civilized places, it doesn't happen every day. And so they panic. But one of the concepts that goes through this literature, if you look at it very carefully, is that oftentimes the patient has expressed, although they may not have filled out the official paper, they may not have done, you know, other things, and what the result of this panic is that at the end, this person loses all of their autonomy at this critical moment where they've already said, I don't want these things done, and now a substituted judgment is occurring, and we then proceed with the steamroller of intubation, CPR, et cetera, et cetera, et cetera.
Although if you combine paper number 10 and number 12, it gives you an interesting kind of point of view. They talk about medical futility, and I was of the view that medical futility was a nice concept. It allowed physicians to use their professional judgment to ascertain whether something is futile or not. But they take a more negative view of the futility concept here. They say, like Al did, you don't have to do something which is not going to be useful. But they say futility is typically invoked when a physician is reluctant to provide treatment that may produce a controversial outcome, like survival in a vegetative state. And if you take that idea of futility and then you bring it down to this number 12, they talk about a case in which a patient with a terminal HIV illness refused to consent to a DNR. The doctor wrote a DNR in the orders of the patient anyway, because this doctor said this care is futile. And so
But it didn't tell the patient.
It did not tell the patient for a variety of reasons, but the doctor independently put a DNR without getting the patient's approval because they viewed this therapy to be terminal and futile.
Let me tell you when I had an epiphany on this question. When I was the project medical director for an EMS system in Washtenaw County, where Ann Arbor, Michigan is, I had to take that job. I had to do my 4 years of this. On Christmas Eve, I got a phone call. The ambulance running to get a 78-year-old woman with terminal cancer, lights and sirens, had gone through a stop, it was snowing, gone through a stop sign and killed 2 teenagers in a car. Now, you know, we don't do anything without a price. Every dollar we put into somebody with that feeding tube who hasn't spoken in 2 years, that person who we cannot treat their infection, that's money we don't have for something else. And I think it's emotionally dishonest. I mean, I think it's not talking about what the cycle of life really is. You know, that was a terrible day, and for those EMTs who killed 2 kids, it was the end of their careers emotionally. I mean, I think we got to think about this stuff. We've overblown. We've turned ACLS and resuscitation in the field into sort of this mythical beast. We had a paper, the paper of the year 2 years ago for Rick was this CPR on television. If you haven't read that paper, you should. Somebody, an academic without a life, looked at every issue, every episode of ER and Chicago Hope and that sort of thing. On TV, 85% of CPR was successful. The funny thing was, 85% of traumatic CPR was successful on TV.
And they woke up and spoke immediately.
Yeah, neurologically intact.
Yeah.
You realize we have a public out there that honestly believe, they don't believe the New York and the Chicago and the Los Angeles numbers that say if you go down on the street, and take Chicago for example, the number of people who left the hospital neurologically intact was about 1%. And I think you have to deal with that number and decide, are we doing anything here? Come on, give me a break.
Well, 13 does point out that when you do initiate CPR or ACLS or somebody, when you know that it's going to be futile, it's usually because you are concerned that somebody is going to criticize you for not doing it because the family said to do it, or that somebody was going to throw something legally at you that said you were obligated to do this and you didn't do it. I think Greg's point is that we really kind of need to do the right thing more often than not.
What's weird is that in other countries, they just look at us and scratch their heads like, what the hell are you doing?
Exactly.
They probably have less lawyers there too, though.
Well, you know, they probably do, but the point is we need to take this situation back and talk about it honestly. You know, they're right. Emergency medicine, by the way, constitutes 1.5% of the healthcare dollar of the United States. We're nickel dime, we're nothing. They spend more money on EKGs at HCFA than they do for all emergency care. Just the EKG readings. We're the nickel dime. We got to look at the big money spent on crap which is going nowhere and say, you know what? There comes a time to die. And if we can't say that, I think we're a profession that's lost its guts.
And I think that's the real take-home point, that somehow or another we let these decisions, which really are truly medical decisions, get into somebody else's hands. Nobody knows better what's going to happen to someone, the contracted patient with the PEG tube who comes in, who hasn't spoken to anybody in a year and a half, who now has a fever, and you've got to get your antibiotics on board within 4 hours, otherwise you get dinged by the peer review people.
You do their blood cultures.
Yeah, and make sure you got your blood cultures done too. I mean, we all know that person is not going to change anything. But yet, the reality of it is every one of us is afraid not to give them the antibiotics, is afraid not to intubate them if they stop breathing, is afraid to do anything like that. We kind of go through our regimen, and then we just basically pass them on to an internist who does the same thing, who passes them back to the nursing home, only to come back to us again in a couple of months.
How do you document that on the chart, that the patient is a futile case? And after you discuss it with the family, and you've chosen to not do anything because you know it's futile.
See, there's your point. You said discuss it, but you said discuss it with the family. In reality, what you really want to do is you want to educate the family. So it's not a discussion, because everyone will always be way too guilty to say, don't save my mom.
Our family practice colleagues should be in the room for this discussion, because I fully believe there should be nobody in a nursing home situation or an extended care situation that doesn't have this spelled out, clear, straight. The other thing is we need laws in every state which exempt us from liability for doing the right thing. I mean, come on here. We need to take back control of this sort of situation. It's time now. Because you know what? You're looking at the graying of America, and if you think you got trouble now, Jack, you haven't seen anything. Because baby
boomer problem.
Well,
the number of people aging and the amount of resources that are going to be dedicated to this are expanding exponentially right now. And not just that, not only is there just more of them, but the length of time people live with cancer and terminal illness now with, PICC lines and indwelling catheters and things has been extended substantially, which means that in the good old days, you just died of your squamous cell carcinoma. Now you live, 38 months, 12 of them with a PICC line with 3 bouts of SVC syndrome and 1 PE and 2 GI bleeds during the end, and that's kind of now the standard of management for these, and so that the consumption of resources is going to be enormous.
Anybody
By the
here
way,
from Oregon?
The Oregon people?
No, I trained in Oregon.
Okay.
And I was there when they created the law.
How'd it go?
I don't practice there.
Right.
But still have family there. It is not utilized very often, but people are utilizing it in what appears to be an appropriate manner.
About 6 months ago, I had dinner with John Kitzhaber, who came up with he was governor when the Oregon plan went in about deciding, rank ordering what we're going to spend our money on. And the problem is, and John's not a bad guy, he's really not, but what he has problems with is the fact that our psyche in this country is different than the European psyche. We do not view it as a collective activity. We view it as an individual activity, and yet we expect the collective pot of money to pay for it. You see, we don't need to have a policy in the country about dishes. You can buy fine china or eat off paper plates. Nobody cares. It's when you're using combined money that's everybody's money, then what are you going to do about it? And by the way, there's almost no debates at the little kid end of this thing. Children's care is cheap. I'm just, I mean, you can take care of most kids in the country, not a problem. Everything starts at about, the utilization rate goes up exponentially starting about age 62 and goes like that. Okay, there's almost no 25-year-old who's on 3 meds. There's almost no 85-year-old who's not on 15 meds. And by the way, they don't know which ones they're taking. And by the way, they're probably all fighting each other biochemically at some level. And that's where we are.
We're going to fix that with that. The pharmacist is going to evaluate everybody's meds when they come into the building.
Some very good studies that say that order entry done, put into the computer, it actually had more mistakes than people who wrote handwritten orders.
Every time you're giving someone Malox plus anything else, they'll tell you that the aluminum hydroxide interacts with your drug. So what the order entry with the drug interaction thing does is it desensitizes you to drug interactions. So your whole shift long, you're like, oh, please shut up. Please stop it. No, yes, I know they're allergic to that. And, so by the time you're done with it, you learn to completely ignore the computer because it hasn't told you anything of value on the first 35 alerts.
Couple left. Let's take a minute or two more.
Gifts.
We could do gifts. We could do authors. We could do informed consent. I think the only issue in informed consent that I particularly think is interesting is this business about informed consent for thrombolysis. I don't think we do that very well at all. And I think we're very compromised in trying to do that. And yet, of strokes.
Of stroke.
Yeah.
The 24.
I think that...
Not only do we not do it well, but when the neurologists who are very... there's obviously 2 camps of people. There are some groups that are very gung-ho about this. And I watched a neurologist in our institution come down and try and sell this. I've seen... You could turn on your TV Saturday morning and watch the used Carmen, 99 El Mes. The sell job is exactly the same on the used car as these neurologists coming down trying to sell them stroke. They're like, you're going to be great. You're going to have plush carpets, roll down windows. It's going to be perfect. And I'm looking at them going, don't do it. And so the informed consent really depends on whose view it is with thrombolysis and stroke.
By the way,
on everything.
Yeah. By the way, what they're selling is the 1995 version of informed consent. In 2000, Marler, the guy who did the NINS trial, the analysis of it, published a paper in Stroke, or in Neurology actually, December of 2000, which said, after 90 minutes, there's no statistical difference. None. Zero. Well, that was hinted at in the original trial. And so now they're still all saying, well, it's within 3 hours. It's got to be okay. You know what? There is no current data that says that.
And there's no new trials ongoing. The only ongoing trial, unbelievably, and I don't know how they're consenting people for this or how it got through an institutional review board, is looking at 3 to 6 hours, which we already know is culling the herd. So maybe the answer here is to take the baby boomers who are going to be looking for fetal care and enroll them in stroke trials and
kill
trim
them.
the herd.
And kill them, just in the herd. By the way, anybody here, are you doing intra-arterial TPA at any of your places?
Yeah, occasionally.
Yeah, just understand, you talk about something which has never been proven and never looked at correctly. Have you seen one paper decently done that shows it? There isn't one in the English literature, and yet they're trying to enroll people now without a decent protocol to know whether it works or not. I think that's immoral.
My favorite consent issue, which is not in either of these papers, but it's in the LP Nuances lecture, is the issue of the febrile child who comes in, who you have to ask, you have to get consent for the LP from the parents. And there's a paper that's in the LP section that says that you shouldn't have to get consent for that LP. Because the only time you would even do an LP on a kid is that you were worried about meningitis. And if the parent won't consent for the LP, then you're going to take that kid away. You're going to call it DHS. And so why would you ask the parent to make a cataclysmically erroneous decision? Which is that if you're worried enough about meningitis to do an LP, they really don't have the right to refuse. So just take the consent issue off the table with LPs and proceed with it.
But I think
By the way,
go ahead.
Most of the guys around the country do a lot of medical legal work. Dan Sullivan, myself, Bob Bitterman. We've talked about this, and informed consent is not an issue in emergency medicine. It's informed refusal, which is the danger. It's when you offer something and they don't want it. and you haven't gone through the correct 5 or 6 parts of against medical advice sorts of stuff, that's when you get sued. Informed consent in our business is not an issue. In fact, there was a paper done that looked at trying to find in every state, all 50 states, one case of a child between 1955 and 1985 or 95, something like that, where a doctor was sued for not having consent to
But
do
Greg,
something.
don't you see the
Never
relationship? So you say you want to ask to do the LP, the parent doesn't consent. So the very process of seeking informed consent produces uninformed refusal.
Uninformed refusal.
So the two problems are inextricably linked. Asking for consent produces uninformed refusal. And so I say, don't ask for consent. Do the LP, just like you would do the IVs and the other
That's
things.
right. Never ask permission, ask forgiveness.
How many places do you, I work at 2 different hospitals. One makes you obtain consent for an LP and one has it under the general consent, like venipuncture.
Yeah.
How many places are you, who has to get consent for an LP?
Wow.
So how many don't?
It's all the way you approach it.
All the Canadians, all the Canadians.
Yeah,
The way we do it is you just walk up and it's like, okay, Mom, we're going to draw some blood, we're going to do a spinal tap on them, we're going to get some urine from them, and they go, okay.
Spinal tap? Yeah. Will there be spinal shock?
But you know what? It's in the way. But if you make a big to-do out of it, it's even worse of a problem.
And I don't want a rectal thermometer because it's too traumatic. Can you get the ear one?
Yeah, right.
I mean, it all depends on how you present.
Let me just tell you right now. Since that movie, Spinal Tap, came out, people have the weirdest view of what this is. People think that all that handicap parking we have is for the people we did spinal taps on.
Yeah, they do.
Yeah, and it's a bunch of crap. I mean, it's the safest procedure I do. You hurt more people doing blood gases and starting IVs than you do doing spinal taps. And we're going to give that lecture here, I think, about this. But let me just tell you, it's the safest procedure you do, particularly on kids.
And the nice thing about a spinal tap when you go to do it is you don't have to do the J-code mandated timeout because there is only one spine and it's in the middle.
Well, what about the timeout for a shoulder reduction?
Yeah.
Are you the right person to be reducing the shoulder? Are you the right one? Or laceration repair? The timeout for laceration repair. Yeah, that is a laceration. We're going to suture it. Yeah, that's it. Okay, let's pick.
I got to tell you, though, at our institution about 15 years ago, some gung-ho intern did put the chest tube in the wrong side. And
we definitely have had that.
Yeah.
It's prophylactic.
Yeah.
I would say talk to your risk managers and approach them because risk managers understand that this query for informed consent on LPs creates uninformed refusal and creates a problem.
Right.
So I would think that your risk managers would be with you on this. You saw what the survey was here. It was about 2/3 do it and 1/3 don't. So the only question is which group do you want to be in? It's not like you're a real outlier. There are rational stands for both sides of the argument. So the question to put to your risk managers is that we perceive this as increasing our risk and increasing the hospital's risk, I guess is what you really want to say to them. They could care less about your risk. Increasing the hospital's risk on these meningitis cases. And particularly with the little meningitis epidemics and things that are going on, you can say you can use the emerging infectious disease thing to increase their paranoia. That's always good. Create a state of fear. Let me see who else does that. Bush. Once you create a state of fear about the lawsuits that are coming because of the waves of epidemic, then you can get them to relook at the issue.
But now, be honest, it doesn't have to be hospital-wide. In our hospital, everybody else gets informed consent for their LPs except the emergency department.
What about the JACO? One standard for all floors.
Strange,
yeah,
because they signed when they came in, like Greg said, when they came in and
they signed the piece of paper.
Exactly.
It was one of the things
that for treatment of their conditions. It's in there.
Although you're talking about children, or you're talking about adults? Adults,
both.
You can't do it on them if they don't want to have it done.
Oh no! Obviously, you have to chase them around the department.
The difference in adults is that adults can refuse and they can get their informed refusal. But if a parent refuses for a child,
I agree.
You're going to proceed because sometimes every once in a while in the emergency room you have to remind parents that they don't own their children. They only have stewardship in them. But the state will step in and intervene if their stewardship sucks. And if they're refusing an LP on a kid who might have meningitis, ergo, their stewardship sucks, and you're going to take the kid away and do it.
They put a sign on our ER that you can drop your kids off there. if you don't want them anymore. Now they,
Yeah, that's the
you know,
we
and
have
there's-
the
and there's
Safe
no-
Harbor program in California.
and there's no age limit.
Yeah.
They
No
don't-
age limit on
No,
yours?
they didn't put any age out. You know,
I've got a 31-year-old I'd like to drop off tonight.
I'm taking you to the ER and leaving you there.
God, I'd love to do that.
All right.
Good.
No age limit.
Well,
The Safe Harbor program varies from state to state. Most of the Safe Harbor programs
didn't
give
see
you
any age limit. I just
give you
assumed there
72
wasn't
hours
any.
to drop the baby off you don't want, but they don't usually give you 30 years to do so.
that changed my mind.